Welcome to USMLE SARTI. We are committed to empowering IMGs. We're excited to guide you on your match journey. Don't forget to click subscribe and turn on notifications so you can get notified whenever we add new content. Also, follow us on Instagram and Twitter for the latest tips and tricks regarding everything USMLE. Now, let's dive into it.
Right, welcome everyone. This is an educational session that Dr. Weissman, who is the Director of Clinical Research at Hackensack Palisades, and Dr. Adam Mutut, who is the Program Director at the same program, they will host every 2 weeks. This will be very useful, short sessions that can help you match as well as understand other aspects of the US healthcare system. So before we start on today's session, Dr. Weissman, there was a question about how you manage your research, in the sense the logistics, what do students end up doing and all that. So if you can just start off by explaining your research course.
Yeah, thank you. Yeah, sure. So I get questions about it all the time. I got one this morning. So every month or so we start a new research group, right? We have a WhatsApp group. We have a different topic. Usually we're working on full manuscripts, retrospective studies, or systematic reviews. Sometimes we do case reports and abstracts for poster presentations. But essentially, there's two parts to it. Number one is I lecture every week on different topics of research, methodology, manuscript draft, manuscript preparation, how to go about reviewing biomedical literature, teaching. And then the second component is more of a hands-on component where we work together on a paper, and at the end of the month we submit the paper for publication. I always say, people say, oh, is it going to get published? So, the soonest I've ever got something published was about 2 weeks from submission. That was the best. Usually it's more like 3 to 5 months. Sometimes it can take a year, but we have to be patient. As long as it's submitted, it goes on your ERAS as this is the name of the paper, this is the journal, the status is submitted, and then when it gets accepted, you put accepted. When it gets published, you change the status to published. And it's it helps you not only get used to the biomedical literature and help you with research, but also helps you build up your CV. So I think it's students have found it useful over the years.
Yeah, and we will give you more information about this course, but I didn't want to hold back on this session. So Dr. Weissman, all yours.
Yes. Excellent. Okay, guys. So the point of this is a rapid review on rashes, some of the common rashes that you'll see in the primary care setting and that you'll get tested on the exam. It's very exam focused. It's on a level of the residents, the interns and the second year residents. It's really on that level, even the third years for the boards. So it's a little bit of higher level. Let's start with this question. And what I like to do is we'll go through the question. And in the chat, maybe all of us attending can just put their, A, B, C, or D, just put their answer choice, and we can go through it and talk about it. Okay. So 76-year-old guy has a history of bilateral lower extremity edema, hyperpigmentation, just like we see in the picture. And he starts feeling heavy, he's tired, and his BMI is 30, and this is what you find. Do we want to do a Doppler, compression stocking, start him at antibiotic cephalexin, or diuresis with furosemide Lasix? So you can just type in the chat. Some of us are saying compression stockings. Let's see what all of us are saying, and then we'll go through it. This is a classic. That's why I like to use this question. All these answers are right answers in different clinical settings, but that's where the exam is going to want you to go and make a differential based on this question. So Christopher Shahad, thank you. Yes, correct. The answer is compression stocking. So what is the diagnosis? Maybe you guys could type in the chat. What is the diagnosis? This is it heart failure? Is it cellulitis infection? Is this a DVT? No. That's where they want to trick you. They're trying to, maybe you'd pick A if you're thinking it's a DVT. You think C if you're thinking cellulitis. D if you're thinking it's heart failure. It's not necessarily varicose veins. It's more venous stasis, a chronic venous stasis from with very poor blood supply to lower extremities, and therefore compression stockings work, right? So chronic venous insufficiency leads to venous stasis because the pump doesn't work well of the venous system, and then the answer is compression stockings, right? So this is a classic thing they like to ask. One thing that we see a lot in the clinic, and the exams are starting to incorporate this now, because patients come in, elderly patients, usually 80 to 85, and they have a lot of these marks on their hands. Okay. And they say, they noticed it years ago, but they're just not going away. They're just not going away. I put a cream on, I tried this cream, I tried grad cream, and they're just not going away. What do I do? And the exam tests this now because it's a common thing you see in the primary care office. Okay. So a lot of, yes, we're all on the money here. Where a lot of us are saying reassurance. That is correct. You do not treat this, but what is it? What is it? It's common with old age, yes, but a name would be nice. Excellent. Okay, so this is actinic purpura, very, very, very close. So these are pruritic, macules that come a lot of times on the forearm. And the answer is they're really from minor trauma. So the patient say, oh, I didn't bump into anything. I didn't drop, but it's a minor trauma, literally like somebody tapping you. Minor trauma, because the blood vessels become very fragile in patients who are old. The skin, the dermis starts to atrophy, and therefore you need to just reassure them that everything is fine. This is normal in elderly patients. So yes, absolutely correct. This should be a very quick one for us. We see this. I please nobody pick reassurance here. Do not reassure this ever. Anyone can walk us through this? What do we want to do? Yes, I think we all understand here. You want to do an excisional biopsy. We all know that melanoma has a very characteristic ABCDs to it. Asymmetry. B is the borders are irregular. C is the color changes. D is diameter. So we all know that the ABCDs, this is malignant melanoma. Breslau depth is the biggest determinant of prognosis. And you really want to do an excisional biopsy for this. Okay. Okay. Let's see if we can tackle this question. So this is not an easy question. Actually, very, very tricky question, because drug-induced hypersensitivity, exanthomatous drug eruption, fixed drug eruption, and hypersensitive vasculitis are all real things and present very, 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 very similarly. But the difference is the timing. That's the hint I'm going to give us. The difference is the timing. Sorry, that's easier to see. Should have had my brightness off a little bit. The difference is the timing. And here he tells you that he has this 2-day rash that started after he started this Bactrim, sulfamethoxyl trimethoprim, 9 days ago. So it took him about a week to react. And that's going to give us an answer here. A lot of us are saying fixed drug eruption. Okay, so this is a very tough question. The residents get destroyed on this, on their in-service exam. Let's walk us through this, okay? So when you talk about a type 4 or a delayed hypersensitivity reaction, this is, first of all, it's the most common form of cutaneous drug reaction. That's why the exam is going to go for this one. But it happens like about 7 days, maybe 10 days after drug eruption. So this is the perfect setting, right? This is the perfect setting. He had it about 9 days ago, right? 9 days ago, this happened. And this is exanthomatous drug eruption. Okay, try this one. Exact same scenario, but here it's like 2 weeks ago. It's a little bit longer, 2 weeks ago. And there's oral mucosa involvement and facial swelling. What do we think this is? So SGS is not an option here, but you got to try to pick what they ask on the exam. But here again, we're 2 weeks out and there's facial swelling. So that's not going to be exanthomatous drug eruption. That's going to be drug-induced hypersensitivity. It has a lot of oral involvement and it occurs 2 weeks after. Please, this is very much for the exams. They love testing this. Let's for the sake of time, I want to take us to this this question. The exams like this a lot. Similar, this is a 60-year-old gentleman who comes in with an entire body rash. He has a history of plaque psoriasis, chronic psoriasis, and the rash covers 90% of his body area. A, drug-induced hypersensitivity. B, erythroderma. C, lichen planus. C, D, pemphigus vulgaris. E, SJS. I think the hint here, guys, is that he has a history of chronic plaque psoriasis. That's a very big hint here. This you don't see that much in the clinic. This you see more on the exams. So some of my students with me here are actually saying that it's what would you say?
Erythroderma?
Yes, erythroderma. Erythroderma is it covers about 80% of the surface area, and it's actually very, very common in patients who have a pre-existing rash like psoriasis. Please remember that for the exams. I want to take us to this, which is a highlight, a staple on the exam. We need to know this. We need to recognize this. Let's see if we can tackle this question here. 50-year-old guy comes in with a 2-day history of sloughing of the skin in his mouth, his face. His eyes are unaffected. He has a history of rosacea, which was treated with doxy for 6 months. And the picture shows the lesions. A, bullous pemphigoid, B, dermatitis herpetiformis, C, pemphigus vulgaris, D, Stevens-Johnson's, E, toxic epidermal necrolysis. So some of us are saying pemphigus vulgaris. Any other thoughts? Some people are still saying S. Some people like Stevens-Johnson's. They'll just say Stevens-Johnson's for anything. But guys, in Stevens-Johnson's, would it present with like this is not covering a lot of the body, right? And it's not after starting a medication. He started doxy 6 months ago. You're not going to have SGS so fast. So TEE, first of all, toxic epidermal necrosis is SGS, but to severe and extreme. So he's not going to have that. So the answer is yes. It's pemphigus vulgaris. Very, very good. Nana, sorry if I mispronounced your name, Dr. Bahadari. This is an autoimmune blistering disorder. It presents with flaccid bullae. These bullae are very easily ruptured. So if you look at the picture, you're not going to see a bullae because they're already ruptured. And that's your pemphigus vulgaris, okay? Try this question. Guys, you can't go through a medicine exam without seeing a derm question like this. I know we're not dermatology experts, but they expect us to know this on the exam. Step 2, step 3, in-service medicine training, family medicine, internal medicine. You need to recognize this. 50-year-old gentleman, same thing, sloughing. His eyes and the mouth are unaffected. Here, his mouth and eyes are unaffected versus guys here, he had affecting of the mouth. That's a hint. That's a hint. And here, same scenario, but you see these bullae here. Yes, I think we all understand this is bullous pemphigoid because you see the very tense bullae, and therefore you see them in the picture. They have not yet ruptured. Okay. Very good. I want to end off with this. We have one more question, but I want to do this one. A 57-year-old with a 2-day history of mild to moderate burning, left leg pain associated with a rash. The rash is in the picture. Please, as primary care providers, we need to recognize the diagnosis. But here's asking treatment. But first, what's the diagnosis, guys? Herpes zoster or shingles. Yes, we got that. Now, do we want to give a topical acyclovir? Do we want to go valacyclovir? Do we want to give valacyclovir with gabapentin or valacyclovir with prednisone? So this is where they're catching you. Sija, Iman, Christopher, they're catching you here. They want you to think, oh, I'm telling the residents that there's pain. So why don't we add gabapentin? But guys, this 2-day history is not post-herpetic neuralgia. This is not neuralgia. This is a normal rash. And if you treat the rash, the pain will go away now. So you do not add gabapentin now. Very good for you, Araxin, Randy. You really nailed that question. And Rayan, you're with me this month. You're all over this. So you want to give oral acyclovir or valacyclovir? The answer is B, because you do not need to worry about the post-traumatic neuralgia. Does that make sense? And that's how they trick you. Everyone says, oh, this is a better answer because it is gabapentin. But no. They do not want you to start gabapentin just yet. Okay. This is the follow-up question to that. They love this on the exam, and I see this mismanaged a lot by the residents. And this is our last question for today. We can go on for hours, but I try to keep these very short, very 15, 20 minutes of blitz education that we do every 2 weeks. This is a 57-year-old man on IBD, on adalimumab, a history of IBD. Adalimumab is an alpha TNF biologic, as we all know. Humira. He has mild to moderate burning in the left flank. It's a rash just seen. What kind of precautions do we need him to be on? Airborne, contact, respiratory, or no precautions? So this is where the residents get always tripped up. Some people say it's contact precautions. Some people say it's a respiratory droplet like the flu. Some people say airborne. And the exam loves this question because it's a trick. Most of us are thinking, okay, it's a rash. You probably just can't touch the rash. But guys, if somebody is immunocompromised, either on a biologic or on chemotherapy, you have to treat this like disseminated herpes, disseminated disease. Disseminated herpes, guys, needs airborne precautions like TB, Raxine, like TB, like Iman said. Iman was all over this, like TB, like N95, airborne precautions. The exam loves this. Please, let's understand this. This is the exception to the rule. Generally, you're right. Generally, it's going to be contact precautions, except if they are on immunocompromised or on a biologic, it's airborne. Very good. Thank you guys so much. I plan to do this every 2 weeks between Dr. Trud and myself. So you're more than welcome to join us. I think it's, even though, it might not be so much information, if you do this every 2 weeks, within the next 3-4 months, you'll learn a ton of stuff. Pawan, please, I want to turn it over to you. I'm going to stick on for a little bit.
Yeah, thank you very much, Dr. Weissman. If you have a couple of minutes, because we did get questions on your board review course as well. So can you talk a bit about how that course is run and how that is useful for applicants who may be applying for match?
Yeah. So I'll preface this by saying we do offer every month we have a virtual tele-rotation, which is more in depth than this. It's not really questions, it's more going through cases together from the hospital virtually and working through them. So that's one thing we do is the virtual rotations. But then we have what you're mentioning is a 12-month like review course for the medicine residency training exam. And the in-service training exam, where we do 2 to 3 times a week lectures similar to this for the year. And we recommend it starting way before residency, so that when you start residency, you're very, very well prepared for that.
Yeah, so I've posted that link. Specific questions. What is the duration of each of the classes? Is it 1 hour?
Yeah, about an hour each.
Okay. And which all programs or residents? I know Dr. Atut mentioned 8 or 6 programs. So which all programs are the residents from?
Yeah. So the way it works is that it's lectures we give to different residency programs, about 6 different residency programs, including Bayonne Medical Center, Palisades Medical Center, Inglewood Hospital, Hackensack, different residency programs locally. The residents are on the lecture as well. It's lecturing for their medicine boards and their medicine in-service training exam. So it's on a very high level. And then we have students joining on Zoom to those sessions. So you get to really see the environment, a very academic environment, similar to what I did for my students here yesterday in the hospital when I gave them residents a lecture. Very high level, but it'll help you with step 3, but it's really geared for the residency level,
Okay. And it will also help the applicants probably network with those residents, right?
Yeah. So I mean, there's not much back and forth dialogue during the sessions, but it really does give you an idea of what each program is like, what kind of the didactics are like, how they run, how they work, and overall, I think it's a positive environment for prospective residents.
Okay. Well, thank you very much, Dr. Weissman. Appreciate your time, and we'll see you in about 2 weeks, or Dr. Atut.
Dr. Atut. So we'll switch off every 2 weeks, Dr. Atut and I. So you'll see me next month. Dr. Atut's going to do one on heart failure in 2 weeks, and then I'll be back in 2 weeks talking about some of the screening guidelines that we do for the medicine. In medicine. So very, all very, very high yield topics. All right. All the best, guys. Thanks and best, Pawan. I'll see you around.
Thank you. Thank you, Dr. Weissman. All right. Thank you, everyone. And we will see you in about 2 weeks for another episode of this educational session. Thank you and good luck.
Thank you so much for watching. We hope that video provided valuable insights for your journey. Don't forget to subscribe to our YouTube channel and follow us on Instagram and Twitter. And check out our website for details on how we can guide you to a successful match.